Good. Hello, good evening, good afternoon, good morning, wherever you are in the world. And welcome to the Black Belt Academy of Surgical Skills. My name is David Regan. I'm a professor in the Medical Education Research and Development Unit at the University of Malaya, Faculty of Medicine. For those of you who are joining the first time, welcome. This is a perfect moment to join the Black Belt Academy. And for those who are returning, thank you very much. Although we might seem to cover the same subjects, what we're doing each time is adding a different nuance and more detail to what we're teaching. The fundamental precept with the Black Belt Academy is mastery can only come from attending to the basics on a continuous practice, without which your complex skills will fall apart. So this evening comes to you thanks to iEcho and Dr. Apajita, who's in New Delhi and is on the production side. If you got any questions, please put them in the chat, or you're welcome to actually ask them and interrupt as we go along. This, for me, is your session. Do be mindful, however, when your camera is on, I end up like a postage stamp on my laptop, which is 2 arms lengths away. And since we're going to be focusing on some models this evening down to 2 centimeters, I need to be able to see the model and make sure that you can see it. And that is difficult if everybody has their camera on. But welcome, and let's get started. This evening is focused on the needle, and the needle is the very essence of surgical skill. But I do wonder how many of us understand the anatomy of the needle, how they're made, the decisions behind the needle, and even the history of the needle itself. I've always taken it for granted during my training because you're asked for suture, it's just passed through by the scrub nurse, and the needles are actually laid out on the tray according to the consultant wishes. Now, that's an important element of governance, is that as a trainee, if you're doing an operation and you're doing it for a consultant under his or her auspices, it is strongly advisable that you use the sutures that they are familiar with, such that if you run into trouble, you can call them into theatre to help, and they can pick up and use familiar equipment and familiar sutures. Remember that Lord Barclay Monaghan said that surgical experience is a posy of other men's flowers. So as you work with different trainers, you will come across different techniques and different tools and different needles. Do be curious and ask why you're using that particular needle or what the advantages and disadvantages are. Because it's not an absolute science. It is really dependent on the experience of the surgeon themselves. Now, the first form of sewing was probably tying animal cloth together in skins to form clothes, using thorns and sharpened rocks as needles, and animal sinew and plant material as thread. Now, the early limitation was the ability to produce a small enough hole in the cloth or the fabric or the hide, such that it didn't tear, but allowed you to pass the thread through. And bone slivers were used predominantly because they are noted not to damage the material. And traces of these survive in the use of awls to make eyelet holes in fabric by separating rather than cutting the threads. A point that might be from a bone needle dates back to 61,000 years ago and was discovered in the Sibidu cave in South Africa. Another needle made of bird bone was attributed to the archaic humans, the Denisovans, estimated around 50,000 years ago in the Denisova cave in Russia. It measured just about 3 inches long, and it even has an eye carved at the top through which the string or thread could be put in. It's probably still usable today. A bone needle was likewise found in a cave in the Patok cavern in eastern Karavanka in Slovenia. And bone and ivory needles have been found in Xiangjusan prehistoric site in the Liaoning province in China, dating between 30 and 23,000 years ago. And ivory needles were found in a Russian cave 30,000 years ago. Now, bone and ivory were obvious materials to create needles from, but the first needles probably came with an understanding of metallurgy. And it is the advancement in metals and understanding and handling and the manufacturing of them that has led to an incredible race in technology and development of the needle. And the earlier ones were probably bronze, then iron, then steel, and involved forging individual metal fragments, perhaps as early as 4000 BC, when copper smelting began. And it was only the application to surgery was unlikely before 6000 BC. Later on, metal needles became a specialist craft, and the Hayward records say that in the 14th century, the Cistercian monks of Borsley Abbey near Redditch in Worcestershire converted drawn steel wire into eye needles by stages which are still the basis of manufacture today. And in about 1655, needle manufacturers were sufficiently independent to establish their own guild of needle makers. Guess where? Threadneedle Street in London, although Redditch is still the popular manufacturer in Britain. Now, needles were rarely used in surgery, but their import was realized when Lister introduced sterilization. And then they became rapidly used for skin closure, and their variety changed. There were no whole needle manufacturers, and surgeons requested Glover's straight needles, cell makers, curved needles, and appropriate needles from other crafts. And in 1497, Brunswick invented both the lance and round-pointed needles, whilst in 1575, Paré illustrated a 3-cornered trocar-pointed curved needle without evidence of a groove or eye to reduce the bulk caused by the thread. Salicet in 1275 noted the superior power of a triangular point, and de Monville in 1320 remarked that to suture wounds inside the mouth or eyelids, a curved needle was best. Now, when needles became curved is difficult to actually describe. But with sterilization, needles start to be used at depth, and the deeper you go, the more the curve of the needle. And hence, I suppose it did start in the oral cavity. So if I take a glass here and demonstrate to you with a straight needle, here you go, and I try and move it within the glass, my range of movement is very limited. But as soon as I put a curve on the needle, as here, now I've got a full range of movement at depth within the cavity. And it's only through the development of metals that we have actually been able to expand and develop this curve, which we'll talk about in more detail. So this is where these curved needles came in. And in addition to variations in shape and length and diameter and point, uh, there's a huge amount of demand depending on the surgery and a diverse range of eyes. Now, the original needle was flattened at the end and an eye was made and thread was put through the eye. But you can imagine the eye, and I'll take you down to focus on one such needle, the eye of a needle, even if it's extremely thin and small, the eye of the needle is still the thickest part of the needle. And taking a thread through there effectively means that you've got a double thread. So as you pass this needle through tissue, you've got to accommodate the thickness of the eye and also of the double thread, which, to be honest, is not what we're looking for from a needle. So with the increased sterilization, the demand for needles and the skill of the surgeons meant that we're going deeper, using it on more tissues, and by 1961, there's diverse sizes and shapes and eyes. And in fact, Shrimpton and Flesher at that time were offering 5,000 different needles for purchase. Today, the significance of the eye of the needle is all but disappeared because we all embrace eyeless needles. So after its sterilization, 1887, the first mass-produced sterile sutures were invented. And Johnson & Johnson started manufacturing sterile sutures and using catgut and silk. And this heralded the onset of modern aseptic, antiseptic surgery. But it was in the 1920s that George Fowling Merson, who was born in Ferrisburgh in Aberdeenshire in 1866 and trained as a pharmacist, actually invented the eyeless swaged needle. And he developed a suture company around this. And he worked with his wife in the kitchen and used catgut and tested it on the kitchen maiden, which is the lift that goes up and down in the house, for strength and length. And they set up, he was first employed by J.F. McFarlane in Edinburgh, who was a suture business, and he set up his own company in 1952. And his experiments with sheep intestines and catgut led to the common sutures we know of those times called the Merson sutures of catgut, and he insisted that all his sutures were prefixed with MER, so it's Mersilk and Merceline. He finally rented a house in a small factory in Edinburgh in Princes Street and produced his first catalogue of sutures in 1970. He was in recognition for his services and scientific advances. He was elected a fellow of the Royal College of Surgeons of Edinburgh, who accredit this program. It was in 1949 that Johnson & Johnson actually acquired Merson's company and made a new conglomerate called Ethicon Suture Laboratories, later changed to Ethicon Incorporated. And Ethicon, in 1960, introduced sterilization with radiation, and a bit like Swan Morton and their scalpels. And this allowed the sutures to be sterilized without damaging the packaging and ensuring that the bacteria stayed out. The advancement of sutures is really dependent on the metals. As soon as steel came in, the addition of chromium and stainless steel was the hallmark of most needles. The addition of tungsten and other metals meant that the sutures, needles, became stronger and enabled them to become finer and more appropriate for delicate surgery. And indeed, the swage, which is the fixing of the suture to the end of the needle, was still a hollow cylinder. You put the end in, crimped it, or glued it. Now you can imagine that my fist being the swage, that being the thread, my finger, this was still the thickest and largest part. Ethicon have now produced a needle where the swage is at least the same diameter, if not smaller, than the rest of the needle itself. That is incredible. The first swage end of making that hole to put the thread in was drilled, but now this is done with laser on very fine needles in seconds per needle, even less. And the manufacturing, therefore, has become extremely technical indeed. In 2011, they produced Everpoint, which is regarded as the most hardened alloy available for stitching. And that is actually used in cardiac surgery. And you can imagine a very calcified vessel and trying to take a needle through a layer of calcium. I remember it being introduced at the time. They first called it kryptonite and asked me to try it. It was extremely useful, particularly as the needle now gets finer and finer. It's well known that surgery places stringent requirements on suture needles, and both the needle, the stiffness must be great enough to withstand the forces necessary to penetrate the tissue. Indeed, I have found myself pointing against a calcified lesion in a coronary vessel, amazed at the amount of force that I need. I support the vessel on the other side, of course, with a forceps to prevent it skidding. But if you think of pressure equals force over area, the pressure that I'm applying must be huge. But at the same time as the needles being strong, they must be ductile enough to prevent brittle failure. And although they say the manufacturers enable the surgeon to reshape the needle should it actually bend, I put it to you, if you use the needle properly, it should not bend at all. So why does it matter when we think about needles and choosing the needle? Well, we need to think about it of the size. The size actually determines by the thread that you attach to it, and the thickness of the thread is determined by the tissue that you're stitching and the tensile strength of the suture required that will enable the wound to heal and have enough strength such that it doesn't separate. So your knowledge of healing and the tensile strength and remodeling of tissues is very important in your understanding of what type of needle to use. The second thing is that the needle needs to pass through the tissue and minimize trauma and minimize bleeding. But some of the tissues that we use are going to be so fragile, and some of the types of needles, especially cutting, would be torn by these tissues. So we need to choose a needle that minimizes trauma, reduces bleeding, enhances wound healing, and reduces complications like leakage or tearing. So think about it. It's like choosing the right screwdriver for the right screw, for the right cabinet, whether it's a small screw or big screw, or choosing the right blade for surgical precision. It's got to match the job. So the material usually used is steel, and this is actually drawn out as thin and then cut into segments, which are then bent, which are then ground for the tip. And then once they're cut and ground in the tip, the suture is attached to the other end as a swage. Following this, it goes on for polishing and smoothing. And in some cases, a lubricant is added, like silicone, to enable the passage of the needle through the tissue. Finally, there's got to be quality control and sterilization. Much easier once it's in the packet and using radiation. But another point here is the quality control in manufacturing and all of these things really puts our theatres to shame. After that, they're packaged, and we get that. So we need to understand sizes and the shape of the needle. So I'm going to bring you over to the top, and we're going to look at some of the features of needles and what we're going to look for in our description. So the surgical needles are categorized according to the gauge, which is the thickness in the diameter of the needle itself, the length, and the length is the length between that point and that point. That is the length of the cord length, right? That is the length. The gauge is described, for example, a size 6O needle is much thinner than a 2O needle. The length is provided here, and then we have the type. So why needle size matters is because we need it to think about the precision, the fineness of what we're doing, and my fellow sensei Chris Caddy is a plastic surgeon and reconstructs nerves. We need to have a needle that causes minimal tissue trauma and optimizes wound closure. So let's focus on the anatomy. First of all, this area here is the point. And why I've got red there is this is a no-go area for picking up the needle. Why? Because the end of the needle, if that is the end of the needle, it is shaped and formed and tapered for about 1/12 of the length of the needle. And if you pick up a needle in that area, you will actually destroy the fine machinery and cutting that is required to deliver your point. This area here is the swage. And again, that amount of area is where the thread is buried into the needle. So that's a no-go area, and that's a no-go area. And what we have in the middle is the working area of the shaft that we will come back to. So let's just consider for a moment what types of points that we can see and explain to you some of these mysterious symbols that are almost hieroglyphic on these suture packets. First of all, let us take a regular suture, a bit of metal, tubular like that, and take it to the end and just think about it tapering. It tapers with a round end, a round body needle at the end. Or it tapers to a point with a single point in that. Our other types of needles then come on to what we call cutting needles. And they are demonstrated by a triangle. Now the cutting needle at the end, when you do a cross section of it, is triangular. And there'll be cutting that way, and cutting that way. And this is a regular cutting needle, which is on the concave as the inside of the needle. It's on the side of the needle, okay? And rarely do we see that in surgery at the moment because there's more tearing and cutting of the tissues on the inside, and you are at risk of cutting your own sutures. So the advanced cutting suture, cutting needle, is the reverse cutting, where the cutting edge is on the outside of the needle here. And again, you can see the cutting is that direction in 3 directions. A more sophisticated version, particularly used in ophthalmic surgery, is cutting laterally only. And you can see that this side wouldn't cut and that side would not cut because they are flat. And this is excellent for corneal surgery and separating the layers of the cornea. Machine advancement, however, has meant that we're now able to introduce more sophisticated forms of tips. Here we got a straight triangle, but now we can curve the triangle like that. Or we can actually focus on the tip, and at the very tip make cuts so you've always got a Mercedes-Benz sign. That becomes more sophisticated as we put that inside a circle. Or indeed, now put that inside the circle, and this really indicates the level of sophistication in manufacturing. The tips are becoming more complex, and what this is meaning is that the penetration of the tissue has become accurate without the cutting that we see with the triangular ends. The round body needle, of course, is just exerting pressure all the way around and is just separating tissues and is not causing any tearing or damage whatsoever. So the cutting needles, these triangular cutting needles, are extremely sharp. They will slice through tissues like skin and tendons and ligaments, and ideal for fibrous tissues you'll find in orthopedic procedures. This reverse cutting needle I found in a sternal needle to get through tissues. Taper points, these, are round and gradual. They pierce and stretch without cutting. And these are ideal for blood vessels, intestines, fascia, and common use in cardiovascular surgery. The blunt tip needles push aside the tissue rather than piercing. And these will be used in solid organs like the liver and kidney. Okay, so when you think about the type of needle, you think about the suture that goes with it. So cutting needles being used in fascia and bone usually would have nylon or polypropylene or proline attached to it. Similarly, the reverse cutting needles will have proline or ethanol or polyesters because this offers strength and reduces tissue tearing. The taper points you'll see for Vicryl, Monocryl, and PDS, and these are absorbable sutures that glide through tissues and bowels and vessels without cutting. This is great for internal as we see here, for PDS, for fibral tissues, liver and spleen, and if you're wanting to reduce needle stick injuries. So that is effectively the tips. Now, let's consider the middle of this. Now, before we do that, let's just look at a couple of these things to interpret what they mean. So here we got a taper cut. This is like reverse cutting, but it's tapered at the end, and is 26 millimeters, and it's a half circle. We look at this, that's a half circle, it's 55 millimeters and is table cut. This is a coated Vicor, 22 millimeters and a half circle. Here we've got a reverse cutting, 3/8 and 24. This is the curved triangular one, 26 millimeters, and it's a 3/8 again. So all of these are clearly spelled out on your suture packet. Foley here, taper cut at the end, but it's within the point, so it's not cutting outside. That's excellent suture and common use in cardiovascular surgery. Here is a round-bodied 30 millimeter half circle. And here is a taper point, 40 millimeters and half circle. This description even goes down to the smallest of sutures, 8.5 millimeters, 3/8 taper point, and this would be fantastic for IMAs, internal mammary arteries. Common suture used for coronary vessels, taper point, 13 millimeter and 3/8 as well. The cutting also applies to straight needles. Now, when do you use straight needles and when do you use curved needles? I personally like to use straight needles when stitching the skin. I find them much easier to handle and gives me, in my hands, a better finish. But you have to be careful of the cut at the end. You can seriously hurt yourself and your finger, cut your fingers because of that end. It's the reverse cutting needles that actually have a peculiar body. They are triangular. We can imagine that there's no point the body of a needle being round. Because if it is round and you picked it up, it's not going to sit in the jaws of your needle holder. And in fact, most needles are somewhat flattened in the middle. So that's the diameter of the needle, but it's flattened either side to enable stability and the holding within the needle. And that is the working shaft here. At that point. So the cross-sectional area would be there. So we now need to consider, we're not going to pick up the needle there, we're not going to pick up the needle there, and many trainees are told it's 2/3, 1/3, and to pick it up there. And I was chatting to the cardiac trainee who confirmed that he was told this on a basic skills program. And it was fixed in his thinking. That's the way and point to pick it up. But I'm now going to demonstrate to you that is not quite the way we should be thinking about a needle, because it depends on what you are doing with it and how you're using it on a rotation. So I'm going to introduce another little model of mine to explain this. But as we do that, I want to just focus down on this tip, and you can see how beautifully these things are made. And this is a big needle used for going through. And there's a lovely reverse cutting on that tip of that needle. You can see it change color as it moves from side to side. That's a big needle. Imagine being able to do that on a needle 6/0 in that size. The manufacturing required in precision is just quite remarkable. So coming back to the needles. So the needles are described, and I'm going to use this protractor was actually used by my father, actually. So this protractor, when he was in his 20s, so this protractor was probably 65 years old. So all needles are made in a circle, and we'll come to the rotation in our discussion of this next week. But the needles are described as a quarter, 3/8, half, and a 5/8. So if that's the swage there, and that's the point, we've got quarter, 45 degrees later, 3/8, 45 degrees later, half, 45 degrees later, 5/8 of a needle. Why? I've actually thought to myself, why is it described in eighths? And why is that important? And I thought, is this related to the compass rose and the four cardinal winds of north, south, east, and west, and the intercardinal winds of northeast, north, south, northwest, etc.? But thinking about it, it's very simply 90 degrees, 90 degrees, and then halving the 90 degrees in between. So the first needle we end up with is a quarter, 45 degrees later, 3/8, 4/8, or a half of 5/8 needle. And you need these needles depending on the depth you are suturing of the tissue, but also at the depth at which you are operating. Now, where do you pick up the needle? So if I put my point of rotation, the point of rotation of the needle made on the circle, imagine the needle between the swage here and the point here. The point of rotation is where my finger is. And you need to rotate the needle round and point it into the tissue. There. Okay? So you can imagine on a quarter needle, it doesn't require much movement to rotate it round and point it on the tissue. And that's particularly with small needles. There you go, rotate it round. But if I go now to 3/8 needle, okay, and I then hold the needle back here, 2/3, 1/3, that's the swage, that's the point. If I hold the needle back here and rotate it, you see that point is not going to be pointing into the tissue. So I have to hold it more to the halfway mark, even beyond the halfway mark, such that the point is pointing into the tissue. So imagine that the working shaft is there. If I picked it up as 2/3, 1/3 from there, I would not be able to pronate and supinate or rotate it sufficiently enough to get that pointing in. And this comes down, as we'll combine this with talking next week on rotation, is rotating the needle, supination and pronation. Most people can go from 90 degrees flat, 90 degrees the other way, effecting 180 degrees. But you might indeed be limited in doing that, and certainly limited if you put fingers through the instruments. What happens if I take it to halfway? That's the point, that's the swage. The needle's all the way around here. If I hold it 2/3, 1/3 and moved it, there's no way I'm going to get this point into the tissue. Not at all. So you do need to actually hold it closer to the point to be able to get that pointing into the tissue. On a 5/8 needle, if I put the needle there you see it's almost a full circle. If I picked up the needle there and my range of movement was that, I'm not going to get that pointing into the tissue at all. So the only way I'm going to get the point into the tissue is to hold it much closer to the point, and that's my range of movement. So to fixate on one point of pickup on the needle is actually incorrect. The other reason why it's incorrect is that just imagine that I had something really solid that I wanted to point my needle into. I am not going to be able to put any pressure on a calcified vessel if I held it out here. I'm not going to direct the force to the point and through the calcified tissue. And this is even with coronary vessels. Therefore, I hold it not in the no-go zone of the tapered point, but as close to the point as possible. I place my forceps where my fingers are on the other side of the calcified vessel, and I squeeze the two together. You can see now I'm applying direct force to this calcium, and it's not likely to skid. Whereas if I hold it here and try and push it through, it is likely to skid out the tissue. So you've got to understand what you are stitching. And this ability to pick up and rotate the needle will reinforce next week, because you will realize if you've stitched a button on a shirt that if you don't take the needle perpendicularly to the tissue, it is a great deal of difficulty. And this perpendicular to the tissue is vitally important if the needle is going to pass between the warp and weft of the fabric. Likewise, the warp and weft of your skin, of the tissues, a bit like my fingers here, needs to go at 90 degrees. So your pickup of the needle is really dependent on your ability to rotate the needle back and present it at 90 degrees to the tissue. And this is what we're going to reinforce again next week. Therefore, understanding the curve of the needle is also understanding what you want it for. So a quarter needle, okay, is only if you've got something, a shallow curve for surface level or easily accessible tissue. 3/8 needle is most commonly used because it's a balance between the depth of the tissue and control. And the control is much easier, as I've demonstrated, with a 3/8 needle, because your standard pickup would be appropriate to rotate the needle back to 90 degrees to the tissue. The half circle, all right, is ideal for deeper cavities, okay, and it requires a better rotation, and we'll discuss the rotation next week. Suffice to say, I do not believe the rotation is with circumduction of the wrist, and I'll explain why next week. Lastly, the 5/8 needle is very curved, and this is perfect for very confined spaces where you want to move the needle around within the space. So why use 8ths? Well, the 8ths really give a quick visual and functional reference for the circle. And if you think about it, as we started with 90 degrees, now we're going to bisect those 90 degrees. Hello, we've got 8ths, quarter, 3/8, half, 5/8 around your needle, each of those being 45 degrees. And I think it was simply geometry and mathematics bisecting 90 degrees that actually enabled the surgeons to think about this, because 90 degrees is the perfect angle, fourth part of the circle. Divide those at 45 degrees, and we'll see this later. So really, what you need to do is match the surgical procedure with a needle. So in cardiovascular surgery, we use small tapered needles, 3/8 curvature to suture blood vessels without leakage. With ophthalmic surgery, we use ultrafine spatula needles, 9/0, 11/0 to minimize corneal trauma. In orthopedic surgery, you need reverse cutting needles for dense tendons, tissues, and ligaments. And for gastrointestinal surgery, you don't want any cutting at all. You want tapered needles with half circle curvature to reduce path. bowel perforations. So there you have it. And the key to using sutures is really understanding the tissues, the geometry, the size of the thread that you want to carry through the tissue, which is going to be determined by how long it takes the tissue to heal, reform, and gain its tensile strength. Blunt needles, yeah, critical evolution in surgical instrumentation, and because it's pressing the tissues out and not cutting anything whatsoever. So all these different needles with all the same hieroglyphics on it, all describe round-bodied, 40 millimeter, tapered, that's the length. All describe what you're going to get in the packet. It is as simple as that. But it's important to understand the needle that you're going to use, because if you don't, you could inadvertently be causing damage. And one of the best ones is I've been running a par excellence course for cardiac surgeons for 22 years. And Martin joined me on the course in Hull. And we were using sutures to stitch prosthetic valves into pig hearts. And he said, have you looked at the type of needle that you use to take through the cuff of a valve? I said, no. And in fact, the manufacturers stress, do not use under any circumstances a cutting needle through the cuff of the valve, because it might damage the fabric and integrity of the valve itself. So to close off our discussion on needles, not only do you not need to know the pathophysiology of healing, you also need to know the thickness and the depth of the tissues and the depth of the operator. One of the simple things to think about is very thin tissues don't need big needles. And the whole thing about a needle in this curvature, you've got to use the needle and use the curve appropriately. There's no point forcing it in and forcing it out, because that will cause damage as well. So you can imagine if you've got thick tissue with a lag zone of inflammation either side, your needle's got to be big enough to go through the whole tissue and out the side, including the lag zone and including the depth. So in other words, if I bring it over to the top and just demonstrate a theoretical wound for you, if that is the depth of the wound, okay, and we've got an inflammatory lag zone either side, your needle is going to pass through effectively the depth of that tissue. And if I bring that together as a wound, as primary closure, your needle needs to pass through, avoiding that lag zone and the appropriate depth of the tissue up that side on the curve. Okay? So you're using the curve to bring the thickness of the bowel, vessel, whatever together. So that is how you determine the size of the needle, but also thinking about how big a thread. You can imagine to take a piece of skin, string through tissue, I need a very, very big needle, probably of that diameter. Might be useful for sewing hides together to make cloth. So to round this off, let's just think about our needles. Needles are sharp. The incidence of injury to the surgeon is actually relatively small. A needle stick injury is about 2 to 10%. It's interesting, it increases with the bigger needles and the sharper needles. In orthopedic, it's in orthopedic surgery is about 1.8%, in cardiac surgery 0.8%, and I think, is dependent on the size of the needle. The risk of getting hepatitis C from a surgical needle actually translates to 0.0001 to 0.052% per year, or 0.035 to 1.12% over a 35-year career. Now, because our needles are not hypodermic, that means when we are using lightness of touch instruments, we as surgeons quickly realize the point in stabbing. Whereas hypodermic needles in casual environments on the ward where there's not the discipline of sharps, they become problematic because the inoculation through the hypodermic needle is much higher, and the risk of hepatitis C transmission is high as well. The needles are sharp, and it's your responsibility as the surgeon to ensure that the needle count is correct. This is important, that the needle count is like the 3 dings that you hear in an airplane when we reach 10,000 feet. That indicates that the cockpit is now sterile, and nobody should actually enter or interrupt the pilots from 10,000 feet to landing. Likewise, at the end of the operation, there is a pause, which is crucial to ensure that the instrument count and the needle count is correct. What to do if it's not correct? Well, in cardiac surgery, we use 6-0 needles, 7-0 needles, and occasionally 5-0 needles. And to lose a 6-0, 7-0, or 5-0 needle in the chest is extremely awkward because they are not going to show up on an x-ray. Because if you've lost a needle and you can't find it on the towels or drapes, and sometimes opening up all the swabs and taking out all the drapes, running the magnet over the floor, then if it's more than 5-0, in other words, a 4-0 or bigger, you are duty bound to x-ray and look and find that needle. That becomes a real problem because the patient's on the table and open for a prolonged period, longer anesthetic, they're cooling, and you've got increased wound infection. Prevention is better than cure. And if the nurse says we're missing a needle, stop, cover the wound, help look for it, but also discipline yourself as a surgeon. Accept the needle in, accept the needle out. The same with your swabs. It is your responsibility to ensure they are properly counted. And that's why the scrub nurse has either got a plastic pad or a foam pad into which the needles are put, and the foam pad is numbered with the types of needles that you're using, so they can be counted in and counted out. And it's got to be correlated with what is on the board as well. I recall a now senior cardiac surgeon who was training at the time I was training, who left the needle on of the pacing wire. When you think of the pacing wire needle, it was probably similar size to this 3-0, and was on the curly bit of proline that we used to fix them in. And he didn't cut it off and proceeded to close the chest. The scrub nurse actually said, there's a needle missing. It's on the end of that pacing wire. He said, yes, it'll be fine. And the anesthetist frowned. He closed the chest, he went out, and then came back with his tail between his legs, confirming that he'd been told to reopen and retrieve the needle. Silly person, very silly. But the responsibility is entirely with the surgeon. So on that note, I would like to actually ask my fellow sensei, Prof. Sile and Prof. Paddy, to join the conversation and give their thoughts about their experiences with needles and their understanding. Thank you.
Hi, David. Once again, exemplary discussion. There was so much in that that I personally learnt, so thank you. Um, a lot of this highlights the need for NOTS, the non-technical skills, as well as the technical skills, because needle stick injuries are far more common than we perhaps like to admit. And if you test your gloves at the end of the procedure, you will see that there are often holes there which you were not aware of. So it's one of these unknown unknowns, which you need to be very aware of, because you don't like to admit that you stabbed yourself with a needle, but you may have felt it, but not admitted to it.
True.
And it is about, yeah, because you're responsible for that needle. When the nurse says we're missing something, you need to think about it clearly. We use a lot of micro needles, which are even finer than the ones that you've been describing. And when you lose one of those, they do not pick up on an X-ray at all. And the
Yeah.
X-ray needs to be at multiple angles before you can find it anyway.
So what needle
So,
would you hunt for? What size would you hunt for?
um, well, I wouldn't use it for micro needles. I accept
Yeah,
that I've lost.
as at cardiac needles, 550 is the biggest. 50, 50 is still very difficult to find. 6 and 7 you'd never find.
Yeah, well, I'm looking at sort of 80, 90, 10,
Yeah,
and you need to include in your demonstration 11 and 12 needles, which are tiny.
yeah,
Um,
yeah.
and if you leave them in a wound, it's not really going to make any difference. But it's about the mindset, setting yourself up for success during the whole procedure.
Exactly.
But I do think that our trainees should, at some stage during their training, turn to the surgeon and say, why do you use the sutures that you do? Why do you use the needles that you do? Because I think if you ask most surgeons, why do you use a 5/8 needle and not a 3/8 needle, they will not have a clue. They do it because that's the way that they were taught to do it, and they always do it that way. Oh, very good. Thank you.
There you go. There's an ATO needle for
Yeah.
you. All right.
But
There's an
put
ATO.
your finger next to that so that people can see the relative size. So that's the size of it. And once again, so when you're operating with needles like that, you need to have a background so you can actually see the needle.
Well, that's why
Otherwise,
in this packet it's an orange,
yeah,
isn't it?
yeah, it's
You
so
wouldn't
you can see
otherwise
the
see it. You
needle.
wouldn't otherwise see that. That's smaller than a
Otherwise,
pinkish.
it just disappears.
Yeah,
Yeah,
and that's less than a third of my fingernail,
yeah.
and that's 80. And you've gone down to 11 and 10, which is an astonishing involvement in uh, metallurgy and manufacturing. I think it's incredible, absolutely incredible. So, hi there, young man. Welcome. You've become a regular on the Black Belt Academy, haven't you? So, yes, it's as Sensei Caddy says that if you lose a needle, it's your responsibility and don't close until you find it. I think anything above 50, you should be able to find a 40. But if you're disciplined in actually putting your needles in and putting needles out, and you're aware of what you're doing all the time in the stage of the operation, you and the scrub desk together identify at which stage that needle was lost, which will help you find it. Sensei Sile, your thoughts.
Hello,
Sorry,
Prof.
Chris, you muted.
Yeah. Hello. Hi, Prof. Thank you very much. Very dedicated teaching, and it is really fine-tuned to understand the needle, Prof. I think I 100% agree with Prof. Chris as well. It's like we have to take a full responsibility of the counting needle, even ourselves. I think in my, more than 30 years of experience that we had a one referral from the district hospital that the lady after the post-delivery in 2 months, she got very intense perineal pain, after, she had an episiotomy repair done. But actually, is that when we investigated, and then that was the whole needle was in the episiotomy, the old area, that the old sutures area. So the whole needle was there, and then of course like X-rays and MRI and all that, and then later on we have to explore it. That is it is really worst scenario I ever heard in my life. Yeah.
Gosh, and what a
Yeah.
sensitive area to lose a needle.
Yes, I think when we investigated, that's in a district hospital when they were very short of staff, and someone, the house officer was suturing, and then it's like no one helps apart from the midwife, and then they lose counting, so it's like a kind of the deep tear and about the except episiotomy as well. So it's like they've been keep opening that one suture another, and then they lost count. So that is very much devastated, and then it's affect the quality of the life, and of course that it raised to the medical legal, so
Understandably.
but everyone should take the responsibility, for counting this. Yeah, this is crucial as well. And also the documentation, Prof, like in now not like we train our trainees that not just write TAH BSO done or LSCS done or episiotomy repair, we keep reminding them in each and every layer to write it down, and then what sutures you use. So it's like this keep reminding us the right suture used in a right tissue as well. And then also as Prof Chris remind us that why we choose this suture, why absorbable, why non-absorbable, and
Exactly.
so yes, Prof, yeah, but I think documentation also is important. Yeah,
That's
thank
a
you.
very helpful and good reminder. Chris, you had
Also,
something to add.
it's important to move away from a blame culture. So it's
Yes,
the
Prof.
surgeon left it in the wound to a sharing culture. We're
Yes,
all
Prof.
responsible for the outcome from the operation and join together in that process.
Yes,
Indeed.
Prof.
It's
Yeah.
about setting yourself up for success. It's the system in which you're working.
Exactly.
Yes, Prof. Yeah.
Exactly.
And not only the whole entire needle, even sometime like, when you prick many times, the tip of the needle might broken as well. So if like being as a surgeon, if you notice that needle is getting curved, or, that the point part is like getting, misshaped, and then you should be careful about that. That tip might be broken as well, and then left inside the human tissue. Yeah.
Excellent. I'm extremely grateful for the comments that are being made in the chat room. That's very kind of you. And I'm delighted that it makes sense. I'm also delighted that our colleagues from Sudan have been watching, and I'm joining them on a conference call tomorrow to see how we can actually help learning and training. Next week, we're going to continue the story of our needle skills, where we are now going to apply our needle to a needle holder and how to pick it up properly. The needle driver is there to enable you to move the needle through the tissues with accuracy and precision. And that accuracy and precision can only be achieved by understanding some of the geometry and the alignments that are required. So we look forward to seeing you next week and hope that you'll continue your journey of learning with us as we explore stitching in detail. As I said, I've deconstructed this further and hope to offer you more opportunities to practice skills, and suddenly realized that I've left a piece of liver and some chicken actually in the fridge to demonstrate some of these factors to you. I will bring them out next week because I think it'll be useful to see what sort of damage can be done by poor use and poor control of your needle. Thank you very much indeed for joining us this evening. I'd like to thank my fellow senseis, Chris Caddy and Prof. Sile. It's been a pleasure you joining, and hope that you fill in our feedback questionnaire, and please spread the word. We are wanting to improve surgery for the better for everyone. Thank you.